So dear participants, my name is Mariangela Pellegrini. I'm a project manager for the European Reference Center for Rare Hematological Diseases, the ERN-EuroBloodNet, and it's my great pleasure to welcome you on behalf of the ERN to this session of the EuroBloodNet Thursday webinar. These educational activities is for promoting the interest on very innovative topics in order to stress among health professionals the cutting-edge advances in the field of rare hematological disease. So today, with this aim, we are going to assist to a lecture on chronic myelomonocytic leukemia, held by Professor Raphael Itzykson. So dear audience, please welcome with me today's speakers. He's Professor of Hematology at the University of Paris, affiliated to the Hematology and Immunology Department at Hôpital Saint-Louis in Paris, in France. So his research focuses on treatment of CMML and on the use of precision medicine tools in AML. Professor Itzykson has published more than 100 articles in peer-reviewed journals, such as the Journal of Clinical Oncology, Cancer Discovery, Blood Hematologic and Leukemia. He's an active member of the GFM, the Groupe Francophone de Myelodysplasie, and ALPHA, Acute Leukemia French Association. He heads the Hematology, Oncogenesis, and Biotherapy PhD programs at the University of Paris. So please, Professor Itzykson, the floor is to you. Thank you very much.
Thank you very much for this very comprehensive introduction.
Perfect.
So thank you. I only my title is broad, but I will mostly focus on the most frequent subset of MDS-MPN. I know we're supposed to talk about rare disease. Chronic myelomonocytic leukemia, so CMML, is already rare. We have even rarer disease. So maybe in another webinar, we could talk of atypical CML and unclassified MDS-MPN, which are a topic of their own with even fewer, I think, scientific and clinical knowledge. So these are my conflicts of interests. Two are particularly relevant to what I will be discussing today, namely research funding we have received, actually not myself personally, but the GFM as a group from Janssen and Novartis. So I think the first thing I should do is discuss with you again what are the current WHO criteria for the diagnosis of CMML. They're going to be revised. We're currently in the process of doing that, but aside from, let's say, the subclassification of CMML, things are unlikely to change very significantly, except for one new diagnostic criterion that can be helpful and that I will develop in details. So the cornerstone of the diagnosis of CMML is persistent peripheral monocytosis, both in absolute and relative values, with no impact of monocyte dysplasia, which is inconstant and sometimes difficult to assess, and no impact as of today of bone marrow monocyte excess. There has been the report of patients that have myelodysplastic syndromes and that tend to have a slight excess in monocytes that do not reach the criteria for CMML. And I will be the first one to acknowledge that this is actually a disease continuum, and these so-called oligomonocytic leukemias are not yet a fully recognized entity. The second thing I must stress is that patients with chronic monocytosis can also have bona fide typical myeloproliferative neoplasms. And so far, the emphasis has been put on these typical MPNs, so that if you fulfill a criteria for PMF, PV, or ET, even though you have monocytes and you have, to some extent, the pathophysiology of CMML clones, you will still be called a PMF, PV, or ET. Some rare patients have monocytosis in the context of eosinophilia due to targetable gene fusions, and obviously these patients are not considered CMML anymore, and this is because these fusions are targetable with ITKs, which is not the case in CMML. The blast count in CMML should include not only myeloblasts and or monoblasts and undifferentiated blasts, but also promonocytes. And this can be sometimes difficult if you don't have an expert, because obviously the monocytic differentiation is a continuum. Evidence of dysplasia is sometimes missing. We used to rely only on clonal cytogenetic alterations, which are found in, let's say, 1/3 of patients. But now that targeted sequencing has become very broadly accessible, it is quite easy to find gene mutations in most patients, bearing in mind that small TET2 clones, for instance, are not sufficient to call a patient CMML, because this could well be clonal hematopoiesis. When we only relied on clonal cytogenetics, we used the persistence of monocytosis in the absence of another condition that can confirm monocytosis, such as a chronic autoimmune or inflammatory disorder or a solid tumor, as being a diagnostic criterion. And I will show you how we can now shorten this phase of observations. There is a subclassification of CMML based on peripheral and bone marrow blasts, as well as one that we inherited from the FAB between the dysplastic, fewer than 13 gigs per liter white blood cells, and proliferative subsets of the disease that remains relevant as of today. The first new thing that I would like to shed the light on is the development or the renewed interest in flow cytometry in CMML. There has been a wealth of paper in the 1990s and 20s showing aberrations, phenotypic aberrations in monocytes, but I mean, the diagnostic value of these were not very well established. And I think now we have, let's say, more than 6 years of follow-up based on this initial report by Dorothée Selimolo-Buet and Oriane Wagner-Ballon, showing that accumulation of so-called classical monocytes that are CD14 high, CD16 low is really a diagnostic criterion for CMML with very high sensitivity and specificity of 94%. This allows you to rule out a reactive monocytosis. Now, I mean, in my clinical experience, I rarely have a doubt between a patient that has absolutely purely reactive monocytosis and CMML. What I do have is patients with some form of autoinflammatory condition or autoimmune condition with whom I suspect an association with CMML, because we know these clinical associations, polychondritis, etc. So Oriane Wagner-Ballon's group has further worked on trying to tease these things out just based on peripheral blood monocytes. They've added a third marker, which is called SLAN, that allows you to identify patients with so-called inflammatory CMML that require a slightly more subtle analysis of their peripheral monocytes with flow cytometry. Standardization is ongoing at the European level. This is an EHA-ELN project actually led by Oriane. And I am confident that these tests, which are, I mean, not super expensive and broadly available, will become part of the diagnostic strategy, probably even in the next WHO classification. Probably won't be mandatory, but will be acknowledged as a helpful tool to make a rapid case of CMML. So the second thing that we have seen in recent years, in spite of therapeutic innovation, is rather a renewal in the available prognostic tools we have at hand. There were actually quite a few prognostic scores that had been developed in the 1990s from the Bournemouth team, etc. But the new wave has, I think, two important advantages. The first one is most obviously the fact that they have been tested in more recent cohorts. The second fact is that they all included in external validation cohorts of significant size. These Prognostic scores come in two flavors. One that I really broadly use in my daily practice is called the CPSS. It's actually not the one we published. It's the one that was proposed by our Spanish and Italian colleagues. And I find it really super convenient because I can do that on top of my mind when the patient comes into the consult for the first time, because it doesn't need gene mutations. It just requires blast with a similar cutoff as WHO, more or less than 10%, white blood cell count, same cutoff as WHO, more or less than 30 gigs per liter, red blood cell transfusion dependency or severe anemia, and cytogenetic alterations. And this CPSS identifies 4 subsets of patients that are named exactly as the old IPSS we used to have in MDS for so many years. So low, intermediate 1, intermediate 2, and high. So because I'm a lazy person, I find it really super useful because I can just copy paste the subgroups of patients that I had in mind when using IPSS for MDS. The second wave of prognostic scores are those that include gene mutations. We published some years ago one that included the ESXL1, and the Mayo Clinic also had one that was prognostic with or without ESXL1 status. And then our Italian and Spanish colleagues expanded their CPSS cohort by including gene mutations, and they could find not only the prognostic relevance of the ESXL1, but also that of 3 other genes. So if you have gene mutations, you probably want to use this GFM or CPSS-MOL score. When you don't have them, unfortunately, what we have shown on a very large retrospective cohort that comes from both sides of the Atlantic is that all prognostic scores really have equal value, with maybe a slight advantage for the CPSS, which again, I think is also pretty convenient. So when I try to decide what will be my frontline treatment option in a patient with CMML, I try to look at 2 dimensions that are not fully orthogonal. They're somehow correlated, but they can be independent. The first thing is, what is the disease risk? I would tend to bin patients in low intermediate 1 CPSS as lower risk patients, and patients with intermediate 2 and high risk CPSS as higher risk, again, lazily, as we used to do with IPSS and MDS. And then I would, in patients with higher risk disease, I really want to try and alter the disease course, and I will discuss with you our recent attempts at showing whether there are some therapies that can alter the natural course of CMML. Conversely, when patients have low risk disease, you really want to cope with their symptoms, and thus you have to prioritize between mostly myeloproliferative, where we usually rely on myelosuppression with Ibrea, or whether we want to address the question of cytopenias. So in the interest of time, I cannot develop all these management strategies. I think the data from ESA is pretty much proposable to what we know in MDS. So I think you can just copy paste whatever you have in mind regarding the use of ESA in MDS. It applies to lower risk CMML. I would just like to put the emphasis on the management of thrombocytopenia. I think it's really important in those patients to acknowledge that thrombocytopenia can be plurifactorial and can be contributed to by some form of peripheral thrombocytopenia, which would be immune mediated. And I'm often not afraid to offer the patient a short steroid course just to make sure that there is no immune component of thrombocytopenia. When this is not the case, we tried some years ago and have reported at ASH, but have yet to fully report that in a publication, the use of single-agent eltrombopag in low-risk patients with thrombocytopenia. This was a phase 2 trial including 30 patients with low-risk CMML, no blast excess, and fewer than 50 gigs per liter platelets. And to make a long story short, the response rate was interesting, with almost half of patients responding, but the median response duration was pretty short. It was only 3 months on average. We had to dose escalate eltrombopag very slowly and precautiously, not so much because of liver enzyme elevations that were not that frequent, but because in some patients, starting at a very high MDS-like dosage as 100 or 200 milligrams per day, resulted in sometimes significant white blood cell count increases that were resolutive upon tapering or interrupting thrombopag. So my bottom message is that if you have a patient that has severe thrombocytopenia or that must undergo some sort of surgery, you may want to use L-thrombopag for a short period of time, but you want to start at 50 milligrams per day and dose escalate really carefully. Interestingly, patients with low platelet counts often have ROUT1 mutations, and this did not impair response achievement. So we really did not treat just ITP associated with CMML. We did treat central thrombocytopenia. Regarding higher risk patients, we all have in mind that the only way we can cure patients with chronic myeloid neoplasms is really with allogeneic stem cell transplantation. So we wanted to revisit that in CMML because when we discuss with our transplant colleagues, they are often reluctant to offer that to our CMML patients, not only because they're old and frail, but because they're aware of these many series and their own experience where the relapse rate after allogeneic stem cell transplantation in CMML is really high, up to 30% in most series. So what we did as a collaborative group worked with together with the EBMT, and this is really an international effort that has been reported at EBMT and ASH congresses, but have again yet to be published, is we gathered data from two cohorts of patients. Patients in the EBMT registry for whom we had CPSS information at diagnosis and that received some form of allogeneic stem cell transplantation during follow-up, anytime during follow-up. We had 384 patients in that category. And patients in our international consortium cohort of 1,800 patients for whom we also had CPSS at diagnosis and we had follow-up information. And to be clear, we used the non-transplant survival data from the ICD cohort and the transplant, the post-transplant survival data from the EBMT to do all sorts of methodological analysis to try to mitigate the many retrospective biases you have when doing this kind of analysis. The first and easiest thing we did was to do a univariable analysis of the impact of stem cell transplant, considering stem cell transplantation as a time-dependent phenomenon. And what we saw is that regardless of the timing of transplantations, performing some form of HSCT in patients that are diagnosed with lower risk CMML is detrimental. Conversely, we did not find any strong advantage nor disadvantage for performing transplant anytime during follow-up in patients that are initially diagnosed with higher risk MDS. And this is true even though we saw, as you can see following the solid lines, that in the long term, there does seem to be a higher plateau in patients that did receive a transplant. So to try and overcome the limitations of these probably time-dependent effect, it's not actually probably, it's certainly a time interaction between time and the risk of death caused by transplant, where you have a higher risk of death in the short term, but a long-term survival benefit. We did what we called a multi-state model that is another let's say, relatively orthogonal method to try and tease out the survival advantage or disadvantage of transplant in this patient cohort. And you may now be familiar with this kind of curves where you will see the probability across time of patients to be in any state, whether being still in the diagnosis state, having transitions to the transformation to AML. We could not actually measure transitions between lower risk and higher risk CMML. This is a pity, but this is the data we had at hand. The probability to be alive with transplantation or without transplantation, and so forth. And thus we could make model scenarios where we would see what is the expected survival of patients with or without transplant 6, 12, 18 months after diagnosis. This is the results for exemplar cases of patients, simulations actually, of patients that would be a 60-year-old patient or 70-year-old patient. Obviously, this is CMML, so this is a male predominant population. So the data we have for male patients is much more robust than that we have for females. So what we see in male patients is that there is always the benefit of doing transplant in higher-risk patients, and always a detriment of doing transplant in patients that were initially at lower risk. So this kind of corroborates and extends our initial findings with the time-dependent analysis. And I think this data is suffering, obviously, from many limitations of retrospective data, but nonetheless, the best data we have at hand that comforts the current expert consensus that patients with low-risk disease should not be transplanted, and patients with higher-risk disease should be seriously considered for transplant. So the second option we have to try to mitigate disease progression in those patients is hypomethylating agents. Now, this is well established in patients with myelodysplastic syndromes. For myeloproliferative CMML, we don't have a label in Europe for hypomethylating agents, and we tended to believe that that HMAs were preferable compared to our standard of care of hydroxyurea, because actually this was the excitement of the decade to use HMAs almost everywhere. This is the only randomized trial we had in CMML until very recently. It was a French randomized trial that was carried in the 1990s, where patients with proliferative CMML and so-called advanced risk disease, and I will come back to that in a minute, were randomized to Hydrea or oral etoposide, and their survival was much better with Hydrea, probably just because of the poor mucosal tolerance of oral etoposide. And we all know that the data we had at hand for CMML, this is non-randomized, mostly retrospective data suggesting that there is some kind of activity with overall response rates, some complete responses, notes reports of regression of myeloproliferative features, and no difference in retrospective comparisons between azacitidine and decitabine. So we were really eager to study the potential benefit of a hypomethylating agents, and we tested decitabine versus a, let's say, standard attitude that would be hydroxyurea. This was the design of the randomized Dakota trial that was carried by the EMSCO in 3 European countries, France, Italy, and Germany, where patients were really randomized to a standard regimen of decitabine or conventional continuous cycles of hydrea. Patients were defined as, the primary endpoint, was event-free survival, and events were defined as death, transformation to AML, progression of blast counts with concurrent progression of cytopenias, or progression of myeloproliferation. And these are the key eligibility criteria. This is the definition of advanced disease that we used in the trial. It's just a copy-paste of what was used in the previous Hydrea trials, randomized trials, so that we have like the same patient populations. It was, even though it was 15 years apart, or actually more than 20 years apart. The only thing, obviously, when the Dakota trial was designed, the CPSS and all these fancy prognostic scores did not exist, so they were not incorporated in the design of the trial, but they were analyzed post hoc. This is the patient disposition: 84 patients in the Dakota, the decitabine arm, and 86 patients in the Hydrea arm. These are superposable populations, maybe slightly younger in the decitabine arm, but otherwise comparable. This is also true in terms of gene mutations. This is the flow chart. I will not go into many details because you know the results that were reported at last year's ASH meeting. But here I'm able finally to present a slightly extended follow-up data. So now we have a median follow-up of 17.5 months, and we still have a median event-free survival of 12.1 months in the decitabine arm compared to 10.3 months in the Hydrea arm, with a hazard ratio for decitabine of 0.83 that does not reach statistical significance, and thus the clinical trial is negative for its primary endpoint. So this result can be considered disappointing, and we tried to understand what was going on. The first thing we could imagine is that decitabine has no clinical activity in this patient population. The first hypothesis is that actually the benefit of decitabine is not seen in all patients, and potentially could be restricted to patients with, for instance, higher risk CPSS, which was like 2/3 of the Dakota patient population. Unfortunately, looking at heterogeneity, performing interaction tests, we did not find any significant interaction with, very simple clinical parameters. So we're not able to tease out a specific subset of patients that would benefit from decitabine over Hydrea, or the other way around. Second potential explanation is that decitabine has no clinical activity at all. So this is not true. The rate of true complete remission using very stringent criteria that account for both myelodysplasia and myeloproliferation was only 12% as best response in decitabine. So it's really in the lower range of what you see with HMA, so it's not huge. But the overall response rate was 63%, which was much greater than the 35% we noted in patients with Hydrea. And in these 35% of objective responses we see with Hydrea, there is, more than half that is just improvement in the white blood cell count with any improvement, as you would expect in cytopenias. So a higher response rate that does not translate into superior EFS. Does it translate into improved overall survival? The answer is no. The median survival in the decitabine arm was 18.4 months and 21.9 months in the Hydrea arm, with no statistical significance between these two figures. Now, we appreciate that because clinicians have a strong preconception that HMAs may be active in these patient populations. A lot of patients that were excluded due to progression in the Hydrea arm received some form of hypomethylating agents after study exit, whether still having CMML or having transformed to AML. So we did an exploratory analysis where patients, it's almost 60% of patients in the Hydrea arm were actually censored at the time they received an HMA after study exit, and this does not change our interpretation of overall survival. That still is non-significant between the two arms. So the last explanation that maybe the higher response rate noted with decitabine was offset by some kind of toxicity. And actually, this is probably to some extent true. This is, as you can see, the cumulative incidence of progression or a transformation to AML, which is significantly lower with decitabine compared to Hydrea. But mirroring this data, the risk of death without progression of transformation was higher in the decitabine arm compared to the hydroxyurea arm. So some unexpected toxicity that we are currently exploring, and there seems to be an excess of infection events in these patients. So I don't know actually how much time I have left, probably not much. But if I can briefly touch upon a couple of things we may want to consider in this patient population is, so we said that we had a higher objective rate of response with decitabine, but what if actually hydroxyurea did something to the disease course? We know that hydroxyurea is really good at lowering the monocyte counts, and I'm not showing you this as a slide, but we know that some of these monocytes do secrete inflammatory monocytes. inflammatory cytokines. So does lowering the levels of these cytokines by lowering the pool of cells that secrete them have an impact on disease course? This is a totally unknown area. I'm just going to mention an intriguing observation that was done by our US colleagues when they performed a phase 1/2 trial of ruxolitinib, single agent ruxolitinib, not randomized, in patients with CMML. The response rate was as high as 38%, but this was not, complete responses. These were mostly improvement in symptom burdens, as you can appreciate on this slide. And there were some clearly lowering of inflammatory cytokines levels, as you would expect from the mode of action of ruxolitinib, for instance, in primary myelofibrosis. And they made an intriguing, though, obviously retrospective comparison, that there may be a survival advantage conferred by lowering these cytokine levels and symptom scores. So maybe even if we don't have drugs that do lower the blast count in these patients, we can still extend their survival by lowering the inflammatory signals that is ongoing and inflammatory damage that is ongoing. So this is, I think, an area for future investigation, both from the clinical and the preclinical standpoint. So do we have new drugs to test in CMML? Yes, we do, but not that many. And many industry or partners are reluctant to launch CMML-specific trials. I would just like to mention a couple of those. One is tagrasofusp, the drug that is licensed in BPDCN. There was a phase 1/2 trial showing some activity, mostly through the reduction of splenomegaly, suggesting that the drug may be active. Whether it does any better than hydroxyurea would do is something that I don't know as of today. But we have to bear in mind the development of this drug in CMML if it ever goes further. And finally, I think to those of us who do translational research, I think it is exciting to know that we are finally coming into an age where we have relevant preclinical models to test drugs or drug combinations in CMML. That comes notably in the form of PDX models that have been published by a number of groups. So with that, I would like to close today's discussion mentioning the EHA ELN guidelines that are available. We published them a couple of years ago. I think they're pretty much relevant as of today, even in the light of the transplant data we have and the results of the Dakota trial. So I invite you to read that and to be aware of how much of what we know and what we do in CMML relies on consensus, expert consensus, rather than high-level scientific evidence. And finally, I would like to thank all our absolutely great collaborators from Europe and from the US. Or even Australia. I think CMML gathers a small group of highly motivated investigators that are very cooperative, and it's very nice to work in this disease area, although we do have to still convert this enthusiasm into meaningful clinical benefit for our patients. Thank you for your attention. I'm really happy to have a discussion with you.
Thank you very much for this comprehensive presentation. So I echo your words. I encourage the audience to raise questions, also because this is a unique occasion to ask to such an expert on the field questions. So let's wait.
Professor Itzykson, this is Nick de Jong speaking from Amsterdam. Can I ask a question?
Sure.
Yeah. Thank you for your presentation. The difference between the hypomethylating agents and the dacitabine, actually, I found it not so big as I actually thought it was. What can you say about the quality of life in these patients? Was it improved in hydrea versus hypomethylating agents? What is your experience?
I think in many patients with dacitabine, it was actually deteriorated. I'm not sure it was improved by hydrea, but it was certainly to some extent deteriorated. I mean, gut feeling is always, you tend to remember the patient that, you know, has received 25 cycles of decitabine and is really doing fine. So, I mean, if you just have a memory bias, then you will always think of patients that have really nice outcome. But I mean, the figures suggest that there are some meaningful toxicities that we have to investigate with decitabine. And conversely, with hydroxyurea, I think you really quickly understand who are the patients that, you know, are going to run into significant toxicity. If you put a little bit of hydrea, they're rapidly becoming anemic or thrombocytopenic, and it's not going to make it for them, and you have to change. And whereas you have patients that, I mean, you know, have blast excess, have seemingly bad mutations, and still fare super well after so many years of hydrea. I have this patient, I saw her in my consult this morning. She has like a very impressive spleen, but she has no significant cytopenia. She fares perfectly well, and she really doesn't want to change her hydrea, even though, you know, she has, you know, 10 kilograms of spleen in her abdomen. I think there's
Thank you very much.
Question in the chat. When should we start hydrea in low-risk patients with proliferature? This is a great question. And I think the answer is there certainly is no value for a cutoff in white blood cell count. I think you should really discuss with the patient and try to see whether there are some objective symptoms. I tend to offer them to take an MPN-SAF test. I'm not using them currently, but I'm gathering them to see whether there is an improvement with hydrea in the MPN-SAF objective. And usually, you know, many of these patients are shy in describing their general symptoms, but when they take the test, you realize that they have many objective signs. Now, I mean, we are in a specific period where a lot of patients would declare, you know, like long COVID symptoms. It's really difficult to know. But I would really trust symptoms and what the patient has to say rather than having a cutoff. I'm really happy with having a patient with, you know, 40 gigs per liter white blood cell count being free of hydrea if he fares super well. And I may be wrong in doing that. I mean, I think it's a trial that we're certainly not going to find any funding for, but maybe actually by killing those monocytes early on, we do have some effect into the long-term disease course. This is really something we have to actively pursue as an hypothesis.
Thank you. There is also another question.
Yeah, I think this is really unusual. So the question is of the correlation between the high white blood cell count and splenomegaly. It's well correlated, but the correlation is not 100% perfect. And I'm going actually to show you something if my screen works well, because I'm not saying that I anticipated this question, but I'm often asked to give a talk on, is there a difference between dysplastic and proliferative CMML? And let me just share, this is the great thing with Zoom is that you can pretty much share whatever you want. So here it is. This is the very large, like it's more than 1,800 patients. And this is the correlation between having a white blood cell count greater than 30 gigs per liter, having the spleen length greater than 13%, and having immature myeloid cells. So for instance, if you look at the correlation between spleen length and white blood cell count, this is dichotomized data, so it's not telling you the full story. You see that there is some correlation. It's probably around 0.5, but it's not absolutely perfect, that's for sure. So I tend, I'm not, I mean, by palpation, we may miss some significant splenomegalis, and you don't often see them in patients that do not have increased white blood cell count, but there could be, I mean, actually.
Okay, thank you. Yes, there is one. So any updates on the significance of KRAS mutation in CMML?
Thanks for the question, Chris. KRAS mutations are obviously less frequent compared to NRAS mutations. To the best of my knowledge, there hasn't been any detail. I mean, our Austrian colleagues, I think, did a large study on the role of RAS mutations in CMML, but I'm not aware of any data that really find any strong difference between different variants, or you could think of exon 2 versus exon 3 of NRAS and so forth. So I don't have any strong opinion on that question. What I can say about RAS mutations in CMML, and I know this is some sort of a personal, I wouldn't say belief, but interpretation of published data that may be slightly different from that of other colleagues, notably people like Eric Pedron. I don't think activation of the RAS-MAP kinase pathway is a universal feature of CMML. It certainly is a universal feature of JMML, but I think we've been together under the name CMML, I think at least 3 groups of patients. The first group of patients are patients that have myelodysplastic CMML. They have a mild increase in the monocyte counts. And I'm pretty confident, and actually published that a few years ago, that in these patients, the monocyte accumulation just results from a tiny myeloid bias of their immature progenitors, such that these patients have higher than normal white blood cell, but higher than normal monocyte count at the expense of erythroid progenitors, and they tend to have anemia in the same proportion as they have monocytes. So that's the first group of patients. The second group of patients is probably around 30 to 40% of CMML patients, depending on your clinics. And these are the patients that have RAS pathway activation. And these patients are hyper-responsive to GM-CSF. So this is those patients that you could test, with some form of a colony assay, spontaneous colony assay, etc. And the last group of patients, which overlaps with the previous one, but is not fully superposable, I think, is patients that tend to have not only monocytic accumulation, but also have immature granulocytes. And these patients are enriched in ASXL1 and ZBP1 mutations, as you would see in a typical CML, because I really think this is a continuum between purely monocytic and purely immature granulocytic proliferation. And the data as to what is the role of ZBP1 in myeloid neoplasms I'm not sure the full story is known. There's some data suggesting that ZBP1 activates the RAS-MAP kinase pathway, but I'm not yet fully convinced that it all converges toward this pathway. And I think this is really relevant to us as clinicians, because there are these MEK inhibitors around, and I don't think they will work in all patients.
Thank you very much. So I see no other question coming. So I will say thank a lot to Professor Itzykson for being here with us and for sharing his time and expertise, and also thank to the audience for the great interaction.